Hello guys, this is the theboggusdoc and we are at the topic HRS and its updates. So HRS is a hepatorenal syndrome. The pathophysiology behind the HRS is a patient with cirrhosis uh, have hepatocyte injury and there is a gut bacterial translocation and there is a increased intrahepatic vascular resistance due to fat. All these will lead to portal hypertension. Is this your intrahepatic vascular resistance will lead to portal hypertension that also move the also do the gut bacterial translocation. These factors will increase the shear stress in splanchnic vessel, also lead to increased production of vasodilator and ultimately lead to splanchnic vasodilation. This is the important part. That will decrease the effective arterial blood volume and it will activate the RAS and sympathetic nervous system and atrial vasopressure that will lead to renal hyperperfusion and water and sodium retention. All this pathophysiology ultimately will lead to are the risk and it will lead to HRS AKI or hepatorenal syndrome. And there is a hepatocyte injury also and there is a gut bacterial translocation. There is three pathophysiology that is important. First is the hepatocyte injury that will activate the damage association molecular pattern and increase the multiple cytokines, inflammatory cytokines and chemokines. Second is the gut bacterial translocation and third is the splanchnic vasodilation. If you see in the old books in the Harrison from the 2000 last recent 21st, they are given HRS in the HRS 1 and HRS 2. It is updated in 2019 2024 that HRS 1 is now known as HRS AKI and HRS 2 is known as HRS NAKI. In the HRS 1 there is some criteria, okay, and HRS 2 there is some criteria that is upgraded. If you see HRS AKD with HRS NAKI is divided into two, HRS acute kidney disease and HRS chronic kidney disease. About the eGFR is less than 60 ml and the serum creatinine less than 50% in 3 months with the eGFR is less than 60. If you see the updates in 2024 from 2015 that the cirrhosis with ascites included, the serum creatinine more than 0.3 milligram per deciliter within 48 hours or serum creatinine more than 50% from baseline value known or presumed to have occurred within period 7 days or urine output less than 0.5 or equal to 0.5 ml per kilogram for 6 hours. There is the absence of improvement of serum creatinine or urine output 12 for 24 hours following adequate volume resuscitation. In volume resuscitation, they include both. It is the volume expansion with albumin and with the other fluids. There is the absence of strong evidence of an alternative explanation like the as the primary cause of acute kidney injury, like the septic shock. There is initially there are the different parameters for these. Now they are included in the one parameter that the absence of strong evidence of an alternative explanation as the primary cause of AKI, including septic shock requiring vasopressus, drug-induced AKI, obstruction or acute glomerular disease. That all are included in this one point. Now, if you see that what is the baseline serum creatinine, baseline value known, these are the parameters that there should be lowest stable serum creatinine value obtained in the previous 3 months, and these are the shit you don't have to remember ultimately when you are not practicing. So, for these PYQ for this PG session, these criteria are important. Now you will see that what is the most widely studied and most promising biomarker that is used in the patient of cirrhosis for the AKI, HRS. It is the NGAL. What is the definitive treatment? It is the liver transplantation. You have to stop the medication that precipitate or worsen the AKI. These are the drugs that cause tubular toxic drug, and the acute interstitial nephritic that drugs that lead to acute interstitial nephritis. Here, HRS is a diagnosis of exclusion. Remember this. You have to stop the diuretic, especially beta blocker, vasodilator, and NSAID. So, what are if patient have hypovolemia? As you know that in the cirrhosis patient, to prevent the hepatic NSF, we have to give the electrolytes. So we have to stop the electrolytes because it will lead to fluid loss and also increase the chances of AKI. So you have to expand the volume. The volume expansion can be by the crystalloid or albumin. So the rate of albumin should be according to a dose of 1 gram per kilogram of body weight for the 2 consecutive days. Okay, 1 gram per kilogram of body weight for the 2 consecutive days for volume expansion in most patients. Remember to see optimize the dose to prevent the worsening of renal function and to avoid the fluid overload, worsening ascites, heart failure, and pulmonary edema. Remember this. As you know, HR is a potential reversible by vasoconstriction medication. As I told you that HRS is because of splanchnic vasodilation. So if you compress the splanchnic arteries, splanchnic vessels, it will lead to more blood in it will the more blood will be available into the systemic circulation, and renal system will get the enough blood. So you have to give the vasoconstrictor, like the approved vasoconstrictor is the terlipressin. So the AASLD and the European Association for the Study of Liver Guideline recommends terlipressin plus, as we told, albumin as the first line treatment for HRS, and the liver transplant. LT is the liver transplant, the best therapeutic option for the patient with HRS, independent of the response to the medical therapy. The mainstay of treatment is to improve the renal blood flow by increasing effective circulation volume through the use of albumin and systemic vasoconstrictor to counteract the artery and splanchnic vasodilation. So what is the best? It is the terlipressin plus albumin best. Instead of only using the terlipressin, you can alternatively use norepinephrine as a continuous infusion, and the midodrine and octreotide is a weak vasoconstrictor that can be used also. So in the previous year question, they gave the option like octreotide plus albumin, that can be marked right answer if the terlipressin is albumin is not given in the option. So I concise this topic because there was only one or two question from this topic. So kindly keep following, keep sharing, and study honestly. Thank you.